Welcome to my world. Another time for exciting moments. Exciting moments because when you are healthy, you can think of excitement. And I bring that excitement with health because if you have no knowledge of what and what you need to do in order to stay healthy, you will continue to stay unwealthy, because health is wealth, and when you are not healthy, you cannot be productive. Knowledge is power. When you have knowledge, you have so much to use in order to be very, very productive. Having said that little much, I now go into the topic I have chosen is nosocomial infection laboratory diagnosis. The first thing you will want to know is what is nosocomial. Nosocomial has to do with problems, infection that we never took into the hospital, but the hospital now pass it on to us. I repeat, we don't have this problem when we went to the hospital for treatment, but the hospital environment, our environment controls almost everything, is the master. The hospital environment now infects us. So this is a very serious concern in developed countries. In Nigeria, I will be going on to the slide immediately so that we look at the Nigerian perspective on nosocomial infection and also the international perspective on nosocomial infection. And like I've always been saying, if you like my presentation, if you like this channel, just click the like button, subscribe as we go on to the slide. Let's look at the slide. Nosocomial infection lab diagnosis. Nosocomial infection are acquired by the patient within 48 to 72 hours or 3 days of admission in the hospital or a medical unit. It has been reported that out of 10 patients in intensive care unit, every one patient gets infected by nosocomial infection, thereby increasing the stay of the patient in the hospital for treatment. The immunocompromised patients will multiple organ failure, burns victims. The mortality rate is very high in immunocompromised patients. To emphasize both hospital and non-hospital setting, it is also called healthcare associated infection because it could be acquired in nursing homes, rehabilitation facilities, outpatient clinic, diagnostic laboratory, or other clinical setting, even from patient's own skin microbiota. Staph infection acquire post-admission devices, water equipment in these facilities. In the developed world, what is their practice like? There is a global tracking and surveillance coordination in developed worlds. They also have programs to reduce the number of hospital-acquired infections. Financial rewards and penalties are implemented for individual hospitals. So the payment policy causes poor performing hospital to lose up to 3% of their inpatient revenue. You can imagine that once you are not meeting up with the standards, you lose 3% of your revenue because they operate this health insurance scheme, and so it's easy for that percentage to be removed. Whereas hospitals that are able to decrease hospital-acquired infection, which means there is a program that monitors the hospital-acquired infection, it earns up to 3% in reward. This is possible because of their medical aid. For example, Maryland recorded, that is the Maryland state in the US, 15.26% decline in the rate of hospital-acquired infection during the first 2 years, 2009, which translates into more than 100 million in cost saving for the healthcare system. In developed world tracking of nosocomial infection, how are they really tracking it? In the United States, the Center for Disease Control and Prevention estimated that roughly 1.7 million healthcare associated infections from all types of microorganisms including bacteria and fungi combined, cause or contribute to 99,000 deaths per year. So it's a serious matter. In Europe, where hospital surveys have been conducted, the category of gram-negative infection are estimated to account for 2/3 of the 25,000 deaths each year. Nosocomial infection can cause severe pneumonia and infection of the urinary tract, bloodstream, and other parts of the body. Many types display antimicrobial resistance, which can really help, just increase the resistant organisms in the population. The Nigerian experience is as follows. The NCDC policy on stemming the prevalence of nosocomial infection is not global in a sense. It is not coordinated from my research efforts. Though one could find in their website that every healthcare facility should set up hospital infection control committee, which is expected to establish and maintain infection prevention and control with its monitoring, surveillance, reporting, research, and education. But there is no name put for coordinator of this program. How is it coordinated if hospitals don't even do them? Tracking is done by creating surveillance system in some hospitals. Yes, from the exposition of their website, you can see how they have done some tracking, but not all, and even that is not regular. I remember Bagada General Hospital when I was the head of department there, and I had to come to the head of the hospital because of continuous nosocomial infection, the high rate of patient having and the wounds are not healing after operation. So all the wards, the theater, everywhere, I had to place plates to really go around, and that experience brought a prevalence of Staphylococcus aureus pseudomonas aeruginosa in the environment of the hospital. That is the general, the GOPD, the SOPD, the relationship we could really confirm, but the colony forming unit was very high. So immediately there was that necessity for disinfection of the hospital, and with that we were able to reduce infection, post-operation infection and nosocomial infection. Individual effort by Nigerian scientists have often shown the statistical analysis of nosocomial infection year in, year out. For example, one healthcare acquired infection over 5 years study has been done by some showing a 2.6 prevalence rate, and most of the prevalence has to do with surgical wounds and operation. Welcome back once more. I'm sure you had an exciting moment watching that slide, because it exposes what we need to know. We need to be very careful that when we go into the hospitals and we see the setup and they are not meeting up with certain safety precautions, then you are likely to go home with serious infection. But let us not go to the precaution, things we are supposed to do immediately. But first of all, let us know the role of the laboratory. The laboratory diagnosis is very essential, because that is the only way you can confirm and say for sure that this infection that I now have, I got it from the hospital. Without the laboratory, can never be any confirmatory diagnosis. You can never be sure. There is no way. But the laboratory will help you to know. So the government, especially the health agencies, the regulatory agencies, would have to put in place certain measures that will help reduce this nosocomial infection, and also all that are aligned with it, because you can easily conclude that the nosocomial infection will aid or is aiding drug resistance, especially with bacteria. That is the multi-drug resistance that is presently being experienced, where you are using drugs, antibiotics that are not working because the body has been exposed to resistance. Because in the hospital, the bacteria are already exposed to all kinds of drugs, so they are mutated to the level that they are now resistant to these drugs. So nosocomial infection is a very serious source of multi-drug resistance. But let us go into the laboratory diagnosis slide and see what we can gain from there. Laboratory diagnosis. You can collect samples for nosocomial infection from all these to examine these parasites, the fungi and bacteria, and from all these areas too, as well as the instrument used. Sample collected from above exposition. You have blood samples collected from patients that are exposed long exudate urine from catheter. Then the theater samples are collected, the ward sample, SGPT, SGOPD, wards, surgical wards, and co. Different type of air samplers are available in the market that will help collect at least 500 liters of air and sampling. The air sampling should be done at regular interval of time, as some people are present at different times. So you want to know that the source is this. 1 hour exposure of the agar medium or Maconke agar, like I did during my time. After 24 hours incubation, a considerable range of microbial contamination with turbulent airflow ranges from 35, but when it's very high, above that's 35 colony forming unit, you suspect that it's causing, you need to disinfect anyway. Hospital, common findings from hospital acquired infections are listed below: pneumonia, gastroenteritis, and bloodstream infection. Organisms that are commonly isolated are Staphylococcus, the methicillin resistant Staphylococcus, Candida albicans, Pseudomonas, Acinetobacter. You find so many of them: coli, tuberculosis, vancomycin resistant, even viruses, as well as malaria parasites. Yeah, finally, we are now at that stage where we can talk of prevention and control. Treatment could also be included. So I would use this medium to tell you that if you like my presentation, I will urge you to subscribe. Subscription has no premium. You don't pay a dime. All you just do is press the subscribe button. If you like it too, press the like button and you'll be notified every time that my production is out. I have always maintained every Thursday, and that is to tell you how seriously and passionately I am about this production. I am so concerned about health. I am so passionate about imparting knowledge. I wish my brain is full of all knowledge so that I can always, without even going to do some refreshing on it, I can just be giving it out to you. Prevention and control. On prevention and control, you have to consider the risk factor so that you know what to avoid. But can you avoid your age? Because it's part of the risk factor. Children, very early, they don't have immunity, and the older you get, you are also prone to have weaker immunity. Health is a serious problem too. Obesity is common with age as well. Diabetes and immunity. Habit, smoking, drinking. Smokers are more prone to respiratory infection. That is very sure. Immunosuppressed drug will really suppress your immunity. So invasive instruments used to inject or help the person to urinate is also a factor. Fully disinfected skin is a way of prevention.
Washing your hand regularly, that is very important. If you want to prevent infection, even at your homes or the home setting, the hospital, anywhere, whether the doctor, the patient, there is a need to wash hand regularly, wearing protective gloves, yes, like face masks and gloves, regular changing urinary and moving them as soon as possible. These are all. Prescribing antibiotic only when needed, not creating antibiotic resistance. Then treatment and control. You have laboratory antibiotic testing, so to confirm the drug that will be very effective, both for the bacteria, malaria, parasites, parasitic, fungal drugs, and so on and so forth. Rest is also very important for treatment. Control, your tracking and surveillance is necessary in order to monitor and control as recommended by the CDC. There must be an enforcer by positive reinforcement of healthcare facilities that are reducing like the penalty and the reward.